Hello class, I wanted to provide a video lecture. This one is about obsessive compulsive disorder, which is more commonly called OCD. And OCD, let me go ahead and activate captions. There we go. So obsessive compulsive disorder, or OCD, is like other mental illness, psychological disorders we've discussed, treatable. And we'll briefly describe treatment at the end of this video lecture. But first, let's talk about symptoms. So OCD is characterized by two symptom groups, and I'll go ahead and share my screen and we'll use the whiteboard. So one symptom group is obsessions, and the other symptom group, whoops, we'll stretch this right out, are listed as compulsions. So obsessions are intrusive thoughts, and those intrusive thoughts are unwelcomed. They just pop in, often people describe, to the person's mind. And this is just part of the way OCD tends to work. Those intrusive thoughts are invasive, they're unwanted, they're unwelcomed, they're distressing, they're upsetting, and it takes almost what is most near and dear to the person, and the symptoms of OCD kind of turns it on them. And typically the content of those thoughts center around three areas: death of self by violence, death of others by violence, and fears or a consistent internal intrusive dialogue about contamination or about infection. And so not all content falls into these three categories. Not all content of the obsessions fall into these categories, but in general, it does. Compulsions are different. Compulsions are repetitive behaviors, and those repetitive behaviors are persistent behaviors that serve a unique purpose. The purpose those behaviors serve are to undo the chance that the obsession will come true. So they're an undoing behavior is how they're commonly referred to, because the idea is performing that obsession will undo the chance that that very intrusive, worrisome thought will be realized or will come true. And when we look at the most common compulsions, it's often referred to as the 3 C's: cleaning, counting, and checking. Whoops. Okay, cleaning, counting, and checking. And so before we move forward, I want to pause for a second, and I want to just kind of broaden our understanding of this, and I want us to apply it to ourselves. And the reason why I want to do this is not because I'm asserting that anyone does or does not have OCD. There's a diagnostic way that you work through it, but instead to just gain incredible sensitivity and understanding of what OCD might be like. And one thing that this is not OCD, the behaviors that I'm going to refer to are statistically frequent behaviors that many people do, and it is not OCD. But I think that by looking at these behaviors, we'll see that OCD is on a continuum, and what drives that continuum is severity, the extent to which these symptoms impact functioning. So on the quote unquote statistically frequent end, therefore we'll say normal, statistically frequent end, we see behaviors like this. So, and this is very common that many people do. So you're in your house and you leave your house and you wonder, did I lock the door, or did I turn off, if you had a device on, did I turn off that device? Did I lock the door? People are sleeping in the house. What if the door is open? What if somebody comes in, etc.? And those thoughts are intrusive. Those thoughts are potentially distressing. Those thoughts are frustrating. And if you just go back and check and make sure you lock the door, then they're gone and you move forward and you're fine. So going back, so the compulsive part of this, the behavioral part of this is, if I can just go back and check, then it's fine. And it's like that itch you can't scratch is now scratched and you don't worry about it anymore. Imagine if you had an intrusive thought that you left something opened and you're continuing to drive forward and you can't turn back, and then it just nags and it kind of spirals and it kind of gets more and more distressing. And that's not so different. It's just not interfering with your functioning. It's just a locked door you can check or not check and move forward with. But when OCD is really becoming distressing, when it's really interrupting the person's healthy functioning, really interrupting the extent to which they are troubled by those thoughts, the extent to which they can quiet down those thoughts, or the hours in which they may spend compulsing to try to undo those distressing thoughts. So then we're looking more into an OCD potential of a diagnosis. There's several things that you work through to diagnose it, but in general. Another example that, so that might be, you know, fear of violence to others, or fear of death of others by violence. Some people with OCD have spoken about that they're in bed alone at night and they start getting these ideas that someone's going to break in, and then they get scared, and then they start wondering, and then they might compulse, so they might do these rituals, this ritualistic behavior or ritualistic thinking to undo the possibility that fear of death of self by violence may occur. That also happens, and that's not necessarily, that might be a little bit less statistically frequent, but that is something that happens, that people will go through times in their life where that will occur. Another very statistically frequent example that hopefully opens your heart, thought, and mind to someone who might be struggling with these symptoms is fears of contamination and infection. Many people might use a public bathroom and feel like it's contaminated, and that contamination is like centered on maybe the flush of the toilet, the little flusher, or the doorknob, or something like that. And so people do many different things to not touch it and therefore not become contaminated. That is statistically frequent. Many people do that, but if you take that and look at it in the ways in which it interferes with functioning, there's some people who believe that when they touch any surfaces that they get poison. They can do a hand washing compulsion that is severe and and has tremendous amount of rules, tremendous amount of time under hot scalding water, to the point of where they can't close their fists because their skin is so taut and dry that they can't really close their fists. So again, it's on a greater extreme. People with OCD typically have incredibly empathic and compassionate hearts, and death of self by violence is looked at the pain that others will experience by the death of themselves, or death of other loved ones by violence, and they compulse because that is their worst fear and their worst pain and their worst worry, or fears of contamination, infection to self or other loved ones, and that consumes much of their day and consumes much of their thoughts because they just are so profoundly impacted by that. And when we look at OCD and its dynamics, it's significantly different than what people think. It is distressing. It is incredibly upsetting to the person. It interferes with their healthy functioning. They're carrying such heavy burdens with the exhaustion of the intrusion of those thoughts. And thought action fusion is also something that can impact the person, because they believe if they think it, then it will actually occur, or if they think it, that they would actually do that act that they would never ever do to harm anybody, or whatever it is. And indeed, it is the absolute pain caused by the symptoms of OCD. The biopsychosocial contributors of OCD are multifaceted, and we look at low levels of serotonin. OCD does tend to also run in families. We look at low levels of GABA, gamma aminobutyric acid, GABA. And GABA is an inhibitory neurotransmitter that turns off the fear network. And so we also look at overactive firing in the amygdala. I mean, there's many biological indicators. And again, I just want you to be aware, I'm not going to ask you to list them or anything like that, or to identify them on an exam. But I do want you to be aware of the heavy biological components of OCD, because we view it to be biopsychosocial, but largely biological. Under the psychological part of it, our bodies are very sophisticated beings, but they cannot tell the difference between a real fear and an imagined fear. And it responds with the same physiological elevation to an imagined fear as it does a real fear. So if someone is truly fearing this harmful experience, their body delivers the sympathetic nervous system activation that would occur if indeed a real threat were being faced. And so our bodies can't discern that. So we have to help our clients discern that. Is this a real threat, or is this an OCD worry? Both are valid. Both we need to work through, but we have to differentiate between a real threat and a worried thought. And so often helping clients with that is at least a small part of the very complex treatment process, but the treatment process does work very well. Another psychological component that we see is the correlation between OCD and potentially overprotective parenting, where it's very worrying, high anxious parenting. And we see that high anxious parenting is correlated with anxious children. And one of the best things that you could do for your anxious child is to work through your own anxiety as a caregiver or parent and demonstrate non-anxious behavior. That is extremely important. Typically, if we have incredible anxiety within, it shows externally and will influence our thoughts, will influence our behaving, will influence our emoting, will influence what we consider to be a fear-based behavior. So working that out internally so that you model non-anxious behavior is incredibly important for anxious children. In addition, with OCD, the person has a tendency to overestimate danger and underestimate their ability to cope with it. So that is a real tough rock and a hard place if you see danger everywhere and underestimate your ability to deal with it. And so one of the things in the thinking pattern, we need to cognitively restructure that, because that is actually grounded in a logic. We need to logically see danger, and we need to logically evaluate our ability to handle it and how we would handle it if indeed it's a real threat. Psychologically, sometimes people purport that OCD can occur after a traumatic experience. When we have seen that, though, it can occur without a traumatic experience. And socially, we do evaluate a culture that overemphasizes worries about different things. Don't touch that, don't do that, don't do that. And not during difficult times like a global pandemic, that's understandable, but during regular day-to-day living that is not interrupted with something like a global pandemic. In addition, people tend to overexpose themselves on fear-inducing news, whether it's through reading it on one's phone or social media or a traditional news outlet. But overexposure to danger through media outlets sets up an anxious backdrop that people who are on this continuum, it can exacerbate their anxiety. In general, treatment is extremely hopeful with people who have OCD. Sometimes the treatment will include an SSRI medication because of its etiology with low levels of serotonin. So sometimes treatment will, at least for a shorter course, be correlated with an SSRI medicine. And psychotherapies, okay, let's try this. Psychotherapies such as exposure and response prevention, and also CBT, cognitive behavior therapy, have been extremely helpful with building a skill set and a repository of skills that you can draw on whenever you need them to help with anxious thinking. So I hope that this video note has provided you with an understanding or at least an overview of obsessive compulsive disorders, of obsessive compulsive disorder. There are also related disorders, and related disorders are things such as hoarding disorder. We used to look at hoarding behavior as a compulsion in OCD. Now we look at it separately when people really struggle to part with items and unfortunately then build a world that is incredibly cluttered in the space around them. There's other related disorders to obsessive compulsive disorder, but obsessive compulsive disorder, or OCD, is the main one I wanted to cover for us.